Hey folks, today we have a very special case which is also a rare one. Yeah, the keratoacanthoma of oral cavity. Keratoacanthoma is a benign proliferative cutaneous lesion and it rarely affects the oral cavity. Or to be specific, it accounts for only 8% of all the keratoacanthomas. Also, the diagnosis of keratoacanthoma is very important, and if you want to know why, this video is for you. Hi, I am Dr. Neha, your maxillofacial physician and radiologist. I talk about my interesting cases in this series of video, and today we have a very classical case of solitary keratoacanthoma. Diagnosis of keratoacanthoma is important as it has a resemblance with the squamous cell carcinoma. In this video, you will learn how to differentiate between keratoacanthoma and squamous cell carcinoma. Also, you will learn about some of the treatment protocols for keratoacanthoma. So watch the video till the end.
So this is my case who is 45-year-old male who was referred to us for evaluation of the lesion in the inferior lip which was present there since 1.5 months.
Patient was an areca nut chewer since 20 years. He used to consume it for 3 to 4 times a day. Patient was a farmer, so he gave history of working exposed to the sunlight for the longer period of time. The lesion was asymptomatic. There was no pain associated with it. However, patient gave history of burning sensation over the lesion on consumption of hot and spicy food, which was majorly due to the presence of pre-existing oral submucous fibrosis.
Clinically, there was an ulcer with elevated and indurated border. Surface was white and size was around 1.5 centimeter in diameter on the left vermilion of lip.
Now, when you go through the literature of keratoacanthoma, the mean age of occurrence of this lesion is around 50 years, and it has a male predominance, and the predisposing factor is mostly the ultraviolet radiation, but immunosuppression can also be one of the factors associated with it. Now, generally, the clinical appearance of keratoacanthoma are exophytic, sessile, erythematous, dome-shaped ulcer with central crust and indurated border. And the size is usually less than 2 centimeter. And those keratoacanthomas larger than 2 centimeter are called as giant keratoacanthomas. Now, you must be wondering that these features are similar to squamous cell carcinoma. Yes, keratoacanthoma and squamous cell carcinoma have marked clinical resemblance, and there are very scanty studies which differentiate them clinically. So it becomes important to do an incisional biopsy. And in cases like this, unless and until there is a histological report, you should provisionally diagnose it as a squamous cell carcinoma. And when we conducted incisional biopsy in our case, the impression we got was of acanthotic hyperkeratotic lesion with dense chronic inflammation. Now, one thing you should know before starting the treatment of keratoacanthoma, that it is a self-healing lesion. It has 3 stages of progression. The first is the proliferative stage, the second is the fully developed mature stage, and the third is the regressing stage. So when you go for the wait and watch treatment protocol, the self-healing of the lesion will take around 22 weeks. So patient has to wait around 5 months for the complete regression of the lesion. Also, you can use certain drugs like intralesional injections of methotrexate or intralesional application of interferon alpha 2b. When you do use this adjuvant therapy, it will give you regression in 2 months, or you can say 4 to 8 weeks. In our case, the lesion was less than 2 centimeters, so we decided to go for the complete excision of the lesion. We did a wedge excision followed by the primary closure, and by doing this, we got an entire lesion for thorough histological examination, permitting us to give a more accurate histopathological diagnosis. Now, one thing you should remember that the histological feature of keratoacanthoma varies according to the stage of progression. Yes, whether it is in the proliferative stage or the mature stage or the regressing stage, the histological features are going to be different, and the histopathologist plays an important role in the accurate diagnosis of keratoacanthoma and subsequently differentiating it from the squamous cell carcinoma.
So the final diagnosis concluded to keratoacanthoma of lower lip. This is the 1 week post-operative picture of the lesion which is showing signals of regression. So that's it folks, it was all about my case which was keratoacanthoma of lip. Now you know how to diagnose keratoacanthoma, how to differentiate it from squamous cell carcinoma, and of course you got maxillofacial physicians and surgeon to help you with it. If you want to see more such interesting cases, do visit my channel. I will meet you in my next video. Till then, you take care of yourself.